Dr. Mahoney, thank you so much for joining us.
Thank you for having me.
A lot of our regular viewers will recognize you, but for newbies, could you just introduce yourself and a little bit about what you did and your day to day before the pandemic started?
Can you remember that far back?
Yeah.
So, hi everyone. My name is Monica Mahoney. I'm a clinical pharmacy specialist at Beth Deaconess Medical Center in Boston, Massachusetts. And for about a year now, I've been working in the outpatient clinic. So I help out with our ID clinic, seeing patients and follow up for HIV, hepatitis C, tuberculosis, and non-mycobacterial infections. And then routine ID follow-up, patients that are discharged from the inpatient that have infectious issues that we need to take care of. And then the other half of my job is also working with our OPAT patients. So patients that are being discharged from the hospital on long-term IV antibiotics, we do the follow-up and the maintenance for them as well. So I used to see patients in person in clinic, help out with the clinicians, our physicians and our nurse practitioner in selecting agents, mitigating side effects, drug interactions, helping out with insurance issues and coordination as well. So I think that's what it used to be, but it's been such a long time now. That
And what is it now, I suppose?
What is it now? My goodness, it's a challenge for us all, isn't it? The core is still there. We still have the same types of patients that we're supposed to be seeing in clinic. How we actually see them, air quotes, see them, is different. A lot of them are virtual visits now. My involvement is more reaching out to the clinicians ahead of time, emailing, paging, or calling any recommendations that I might have noticed. I try to look up in advance before they actually call the patient. And then my interaction with the patient, it used to be simultaneous. We would go in and see the patient together. Now it's a little more asynchronous after they see the patient and meet with them. Sometimes I'll call them up for follow-up after if there's any additional need for me. Um, and it's all work from home. For the past 2 months, I have not been in clinic. I've been fully remote versus the clinicians, depending on what patients they see. Sometimes they still have to go into clinic to see the patient in person, or sometimes they're working from home. So it's a lot of coordination. It's a lot of realizing that what we thought was really good Wi-Fi, in fact, maybe is not quite as adequate anymore.
Yes.
So it's been a challenge, but it's also had some good times too, good moments.
There are some universal themes in there, I think, for the past few months. So I was curious, what proportion of patients that you're working with are continuing sort of the pre-pandemic, the key infectious disease areas that were worked on in the past, outpatient, and what proportion is either COVID or impacted by COVID in some, I mean, everybody's impacted, but to sort of acutely impacted, that kind of thing?
Yeah. So we haven't been seeing COVID follow-up patients and outpatients. I think there's twofold is, some patients that get the infection aren't sick enough to actually come into healthcare. They're told to convalesce at home, isolate at home, and they recover at home. So they don't necessarily need to come into the healthcare setting. The other ones that we have in the hospital are actually staying for long periods of time. My institution has treated a couple of hundred patients, and their hospitalization has been prolonged either in the ICU or then transitioned down to the floor. So we haven't really reached a point where the patients might need infectious follow-up specifically for COVID. So we haven't seen that in outpatient. What we have seen, unfortunately, is a decrease in the number of patients that are seeing follow-up for their routine ID care. Um, you know, the message has gotten out that this is a contagious virus. We need to all do our part. We all need to stay home. So our patients are scared. They don't want to come in for visits. Those that we can, we transition to virtual visits. I'm actually interested to see in the numbers of no-shows for the virtual visits. From talking to my clinicians, I think the number of no-shows have gone down since we've given the option for patients to have these virtual visits. There is a whole another subsection that if they don't have the technology or the capability or the privacy to have a virtual visit, then that's not going to work. But other patients, we need to see them in person. You can only do so much via the computer or the telephone. Sometimes you need to see the patient, feel the patient, do a physical exam. And the other thing is that we need laboratory values. Patients are scared to leave their house. So whereas they might be more willing to hop on the phone and have a virtual visit, we need those safety parameters. We need those monitoring parameters. Previously, when we had patients come into clinic, we'd say, okay, here's a lab slip on your way out. Just stop into the lab, get your blood drawn, and we'll have the information that we need. Now, because we're seeing the patients in their house, they're not coming into clinic, so they're not stopping by our laboratory. We have partnered with outpatient labs to try to get those results, but patients are scared to leave. They do not want to catch this virus, and they think that any leaving of the house will put them at risk. So whether that's going in to get a blood draw for laboratory parameters or whether that's coming in for an in-person visit, patients are deferring and they just don't want to come in.
Right, and that's something I think as public health communication was it was so effective that happened. I've seen a kind of pivot to having to emphasize, listen, if you're having a heart attack, come into the hospital, things
Yes.
of that nature, just
Mhm.
because of how you see on the news the exceptions of people who maybe don't wear a mask, don't social distance at all, but most people either lie somewhere in between or are taking it very seriously. I would think, in my own life at least, I've observed. And so how do we, on a bigger scale, there's this sort of public health, we've heard about things like, and some of the modeling that's come out around tuberculosis, for example, some of the progress that's undone there by not being able to
Mhm.
see people in person.
Mhm.
And I'm just curious what you think about it's a tough question to balance priorities, because this is a very serious, this is unprecedented in our lifetimes. And then at the same time, the rest of infectious disease doesn't disappear.
Right. Yeah, I'm obviously in Massachusetts, and where I live, we have a couple of the community hospitals, and I've been seeing commercials for the director of the emergency services making an appeal to patients. They're like, "We are still here. We have safeguards in place. Do not ignore that chest pain. You need to come in. You need to get examined." So I have seen that messaging. Yeah, there is a fine line. We've done a great job of messaging social distancing, but there is this other group of patients that were like, well, social distancing doesn't apply to true emergencies. You do need to come in. And that applies for routine follow up or laboratory visits. And I think if you had a really good relationship with your patients, an in person relationship with your patients before this whole pandemic, it's easier to have that connection, have that discussion with them, and convince them that you do have safeguards in place. Their safety is your priority, but you also do need to come in and do X, Y, or Z because we can only do so much via distance. It's a little harder when we get patients that are referred to us that we haven't seen before because they have a positive quantiferin gold. You mentioned tuberculosis, and we need to examine them. Well, it's kind of hard to examine them or convince them to come in for an examination if you've never seen the patient and they're scared to come in.
Right.
Or they're scared to get the lab tests, or they can't provide, a sputum sample for us to do an acid fast smear. So there are definitely some challenges in trying to convince patients that there are times where you do need to go out into society, you do need to go into a healthcare setting, and then trying to comfort them and tell them the steps that they can take to be safe. Don't take public transportation, take your own private car, wear a mask, wash your hands or bring hand sanitizer. And then the other thing is that all of these healthcare these clinics, these hospitals, we have policies in place. We limit the number of people that can come in. We try to prevent any escorts from the patients from coming in. We just want the patient to come in. We have, intensified our cleaning procedures so that we're doing a lot more disinfecting. If you look at the waiting rooms, a lot of chairs have big red X's on them or signs, do not sit, so that we're trying to do social distancing with having people be at least 6 feet apart that way. So um, it is scary, but at the same time, I think we've done a really good job of minimizing those risks and preventing other people from being there. So you might actually be the only person that's in the clinic besides the healthcare workers that are there as well.
You had me thinking there, actually. I mean, there's this black and white kind of debate about, the lockdown debate that happens in the culture wars or what have you. But when you look at what's happening, practically speaking, it's clear that we're not, in terms of government policy around the world, even the places that have taken this the most seriously, that we're not maintaining, April level social distancing measures like through, the rest of the year, for example, right? We're not going to go back all of a sudden everybody's in a 50,000 person stadium, or, people are still encouraged rightly to wear masks in public and to take precautions. But I think some of that black and white conversation de-emphasize stuff that's actually very important to like preventing a respiratory illness, like, increasing hand hygiene, sanitation, things of that nature. And it seems like we're partially and gradually, it's called reopening. So that's either going to be done safely with precautions, or it's going to be, like a light switch. And I guess what I'm to get off my high horse, I'm sorry, but what I guess I want to ask is, what are some of the ways that as we do this gradually, it can be safe, it can have public trust that we're you've touched on this a little, that we're taking care and taking steps in the clinic, but that, actually proactively, targeted interventions to make showing up to a healthcare setting, you're never going to have zero risk, but less risky.
Yeah, I think unfortunately we haven't had clear leadership from a national standpoint, and I think you do need a leader or a group of leaders that are overseeing all these different areas, and they're able to make these decisions or recommendations. Because right now you look at the 50 different states and we have 50 different ways that we are reopening. Some places are doing it in phases, some places just, floodgates open. And I think in the coming weeks or months, we're going to see whether we have that second wave, that third wave that we saw with the 1918 influenza pandemic. And I don't think there is one course to take. We're going to have to take it week by week and reassess, and maybe we need to pull back. Maybe we need to, reenact some level of social distancing, depending on what we're seeing in the numbers. But I think, there are some common sense things that we can take forward for all aspects of life. It is the hand hygiene. It is staying away from people. It is being more cognizant of yourself and your own symptoms. When you start feeling sick or ill, isolate yourself, take care of yourself. We had a huge problem previously, myself included, of absenteeism. When you felt a little sick, you would go into work. And I think that we need to have better policies in place, work policies and personal policies that, no, I need to stay home. It's not just for myself, but it's for protecting others. And there are, a whole other set of background policies and how we make that affordable for everyone, because not everybody has sick leave, et cetera, et cetera.
I mean, that's
How
such
do
a
you,
sorry to interrupt you. I was just going to comment that that's such a good point. I mean, like, you've seen a lot of kind of demands or political kind of things about safety at the workplace, but at the end of the day, some of what's so damning about the situation is, the work culture in the United States and the lack of paid sick leave.
Mhm.
I mean,
Yeah,
that's a
and
longstanding issue.
I think you and I are preaching from our work from home
Exactly.
high horse or towers that we're able to do this, and there are a lot of people that cannot do this. So it's easy for us to say because we're not in their shoes. So there are a bunch of other changes that need to be made in order to benefit the greater public health. But in terms of the clinics, you know, I don't know how we're going to safely go back to square one. I think we're kind of learning as we go. I think we've made some good steps in the right direction with the masking and the hand hygiene. We have been screening patients and asking for symptoms, and even if we're not sure, better safe than sorry. You know, better put masks on all the patients. If they have respiratory symptoms, instead of having them sit in the waiting room, we immediately put them back in a private room, close the door. If we have filtration capabilities, we would turn that on. Limiting the number of people that we can have come into the clinics or the hospitals with them. And I know that that's a touchy subject as well because mental health and social interaction is something else is an important feature, and I think it differs if it's a quick outpatient appointment versus if it's a long inpatient hospitalization. And I hope that one of the best things to come out of this is the adoption of some of those telehealth visits. I think we've always asked about these capabilities in one way or another, and the message that we got is no, we're not able to do that. We don't have the infrastructure, we don't have the reimbursement that can do this, and this pandemic has forced people to reevaluate that. And now we do have expanded Medicare coverage. We could still have more. They can cover more things. They can cover more providers, pharmacists. Hello. Um, I think it's leveled the field for some patients. We've always had patients previously that weren't able to come to their appointments because they've had transportation issues, they've had mobility issues. So this kind of gives them another avenue to be engaged. So I think when we get back to a more normal, I'm hoping that people sit down and pick some of the good things that came out of this and continue them forward, so we can have more options to get more preventative health care to all of our patients.
Well, it makes me think of some of the work that everybody was doing before all of this on, say, HIV in a rural setting,
Hmm.
for example.
Yeah.
Like you've got clinics that are doing outpatient management of something like HIV, especially where there's stigma, and so you've not only got logistical transportation issues, you've got the question of, how do you blend in an HIV clinic so that people are walking in and not getting immediately kind of out of the
Hmm.
closet about it
Yep.
by their neighbors, especially if you're in such a small town. And this is a solution that really apparently we were capable of all along. And that's one of the things about the infrastructure that you said. There were so many things that we were told were impossible before the pandemic that have suddenly become possible, that are actually very convenient for medical care until after, or I mean, post COVID. And so I appreciate that point. What I wanted to touch on was whether you had any kind of, because I have this kind of general opening the floor kind of
Mhm.
question, and then I have a fun question for the end.
Oh gosh.
But no, I'm not going to ask you like, if you were a kitchen utensil, what would you? Don't worry.
Well, this reminds me that whenever we bring candidates on to interview, I am one of those people that at the very end I do ask them that fun question, and now you're putting me in the hot seat, and I'm rethinking and reevaluating whether we want to
You're
ask
like,
those fun
you're like,
questions.
have I been
So
doing
on
something
behalf
very
of
cruel?
former on behalf of former residents everywhere, they thank you right now.
Yes. Wow. I didn't know I was getting revenge, but before that, I just it's not even that quirky. But before that, I just want to open the floor to you to anything about outpatient care right now. Anything you want to say to fellow clinicians and pharmacists and the healthcare field in general, that kind of comes to mind about some of the issues we've raised here and about care in general. Just sort of general, whatever you'd like.
Yeah, I think something that this pandemic and this whole situation and how some people are going into the hospitals and the clinics to care for patients and some people have taken more of a remote supportive role is that I think we've all realized how much we care about our patients and how much the other clinicians care, and that we're all working together as best as we can to provide the optimal therapy for our patients. I think this has enhanced our communication and our collaboration skills, and I have been very appreciative of my colleagues and my coworkers, and I know I've heard the same from others as well. So there are some silver linings to this, terrible pandemic that's going on. Not to minimize it at all, but I think that you can always look and you can always find some good in the situation as well.
So that actually dovetails with what I was going to ask, which is without any HIPAA violations, are there any kind of moments in patient care that have really stood out to you as hopeful and optimistic and like basically what are you proud of during this time? I mean, I think there's a lot of burnout and
Oh gosh,
I
yeah.
mean, not that there was burnout before and then we just
Mhm.
threw this right on top of it. So I guess I just want to
Yeah.
float um, a little bit of what positivity have you
Yeah.
experienced over the course of this?
One, I think that the spouses and the children are amazing. Mine are downstairs right now. I was half expecting them to bust on in here, but all of their worlds have been turned upside down as well. And I think our children in particular, they've been very resilient and for the most part have allowed the parents to do the work that they have to do. But in terms of patient interactions, I am floored every time I reach out and I call a patient. And sometimes these are patients I've never seen in person. I've identified an issue, or the clinicians reach out and they're like, Monica, can you help us with this patient? When I call them, and I introduce who I am, and I work with Dr. So-and-so at Beth Israel, almost instantly, everyone has been asking, how are you doing? I hope you're staying safe. And I'm like, I've never even met you before. So it's a nice feeling, definitely one that I did not expect, when the patients are very concerned about their providers as well and asking how they're doing. So it's kind of, reignited faith in humanity a little bit.
Absolutely. I mean, I've myself been really floored by the way people are willing to come together in a crisis. I've seen, people I know like that are strangers helping pay each other's bills because of the way the economy's going. I mean,
Mhm.
stuff like that. That's really really heartening. So I appreciate you sharing that story. And thank you for coming by. Always always wonderful to have a regular guest and contributor to Contagion. Nice to finally meet you.
I,
Okay.
I did travel far. Usually I work out of the bedroom because that's the only door that has a lock. So I actually went to the office. So you guys have this wonderful background if Rate My Skype Room is on.
I was about to bring them up. Yeah, okay. First of
I don't
all,
have a kitchen in my background. Yeah, I can see yours.
I would be told to get rid of I would be told to cover the light switch with a plant. Get
I
rid of that
almost brought the
sticky note.
plant from upstairs.
But I hope there would be some appreciation for the wine barrel at least.
Where's the wine barrel?
The
Oh, the
picture behind me.
painting. Oh,
Yeah.
oh.
No, there's not that would be that would help with morale in a lot of ways. But no. All right. Thank you, Dr. Mahoney. Much appreciated.
Thanks for having me. Bye, guys.